Okay, let's move on to the third market, the most pressing market, in my opinion, and the most intractable, healthcare. So ideally, you would have high quality care at a low cost available to everybody. Everybody gets the same care, it's cheap, and it's really good. That's the ideal. The issue is there's always trade-offs. So the issue with anything is you got to give up something to get something else. With healthcare, it's really complicated, but in general, it's impossible to increase quality, decrease cost, and increase availability. And oftentimes, what happens if you push on one of these, you're actually giving up the other two. So if you push on quality, it's more expensive, and then it increases the inequality in terms of only the wealthy can afford that high quality care. Um, many places are lucky that when they push on two, they only give up one, but it's just an not intract, but it's a tough problem to try to achieve all four of these. Typically, you kind of have to choose which one you're going to maximize on. All right. So in general, a healthcare system, the questions are, how are we doing insurance? Are we going to have pure private markets where people shop for insurance? Are we going to have a public insurance provided by the government where the government says, okay, everyone has this specific insurance? Or the government says you can choose from these different insurances? We're going to do compulsory. So we could do a mixture of private or public, but we make people buy it. This would be like a mandate. Or are we going to do employer-based, where people predominantly receive their insurance via their employer? We need to decide who rations care. How do we ration care? In a market setting, price rations something. So in a market setting, if you want to buy something, how do we decide who gets it? Whoever wants to pay the price. That's the rationing system in a market system. In sort of a government-run system, would be like, the government has to decide who gets it, who doesn't get it. In the context of healthcare, there needs to be, again, somebody who decides, are we going to deliver this service to this person? So you could imagine a few different mechanisms. So if we had a pure private free market system, which doesn't exist anywhere, you would say, okay, the person would decide, all right, do I want this service? If I want to pay the price, I get it. If not, I don't. An insurance-based system would decide, all right, is this covered? Are we going to cover this service, or are we not going to cover this service? Okay. And then if it's not covered, then the person could pay out of pocket. In a government-run system, the government would say, okay, these types of services are covered in these types of situations. But somebody needs to make the decision in terms of who gets what service and when. You could think of, some sort of life-saving treatment, or not life-saving, but something that extends your life by a day. Something that costs $100,000 and it'll extend someone's life by a day. Maybe a more realistic one would be like 2 months, 3 months. This often happens in cancer settings where there's a treatment, costs $100,000, $200,000. It extends life by 2 or 3 months. Okay, who pays for that? Or are we going to provide that service to the person? All right, in a market system, they would decide if they want to pay it or not. Insurance system, the insurance would decide if they're going to cover that or not. Government system, is that service under the umbrella of services offered? Okay. In the context of the Affordable Care Act, this is what was like characterized as death panels, where the government would have to decide what treatments are covered or not. Lastly, we have to decide how providers are regulated. What type of regulations are going to be, who's going to be the regulators, et cetera. All right, and so basically we can break down the world into three different types or the developed world into three different models: Beveridge model, Bismarck model, and the American model, which is unique to us. So the Beveridge model is essentially just government-run healthcare. It comes from the UK. So you find it in the UK and the UK's offshoots, Canada, Australia, New Zealand, and then the Northern European countries typically have government-run healthcare, where the insurance and the healthcare services are provided by the government. So the physicians are actually government employees. And so here, if we're going back to up here, this one is really going to emphasize equality, where everybody has access to the same level of service. All right, but you still have this rationing problem, where if the government's providing it, you have to decide who gets it, who doesn't get it. So the mechanisms here are queuing. So since this is an English system, we use the English term queuing instead of waiting in a line. So typically for non-life-threatening procedures, there is a wait time. It could be a long wait time, it could be a short wait time, kind of depends on the country, depends on the procedure, depends on the time period. So the queuing in the UK got really bad. They made some reforms that have brought down the wait times. But it's sort of the reason why it's rationing. It's like, if we have like a scarce resources, we're going to give it to the people who need it first. You kind of have to wait. I experienced this when I lived in Spain, where I injured myself playing basketball. It was not life-threatening, but I would have had to wait months to get the procedure that was necessary. Now, in that time, the injury essentially healed itself via physical therapy and other methods, which is sort of the idea, is that some of these are going to take care during the wait. Some of these problems will go away naturally. We're also going to have gatekeeping as another method of rationing. So you have to see a specialist that will then determine if you really need that procedure or not. And finally, this health technology assessment, which, as I mentioned, this is sort of what was, libeled or criticized as death panels, where, the government ultimately has to decide, are we going to adopt this technology? Is this technology, is it worth it for its price? Are we going to put this under the umbrella of services offered in our hospitals that we run? So are we going to adopt the latest MRI machines? Or are we going to approve this type of test in this setting, or this type of treatment in this setting? And that's a cost-benefit analysis. The government essentially is going to have to say, is it worth the costs? And this is called health technology assessment. And it's like a whole field, and there's like a whole, math that goes into deciding, whether you should approve technologies or not. This, in these countries where the government runs healthcare, this becomes very contentious, because you could think there's a treatment out there, but it's not approved by the government, or it's not offered by the government. Typically, people don't like that. So this becomes very contentious. The Bismarck model, named for Otto von Bismarck, essentially is the first place where it was something similar was used. Essentially, it's compulsory private insurance. So there's private insurance companies. Some cases are different public insurance options. It varies by country, but you have to buy it. So you have to get insurance of some kind. The hospitals are private, the doctors are private, and then there are often strict price controls set by the government. So the services are kind of capped at certain prices. This tries to balance equality. Like, okay, everybody has to have insurance, but we're allowing some personal choice. That if you want to skimp on the insurance, if you want to get kind of like a basic plan, you can. If you want a more thorough plan, you can do that. So it allows some liberty, while kind of providing equity, and also the price controls are important in keeping the costs down. So Germany, Japan, Switzerland, the Netherlands would all be examples of the Bismarck system. The ACA, the Affordable Care Act, was essentially, the goal of that was to move the U.S. towards the Bismarck system by having that compulsory private insurance. And then ultimately, I think the hope of the framers of that would be to add a public option for insurance as well. And that would essentially bring the U.S. more in line with the Bismarck system. But the Affordable Care Act has been gutted under the Trump administration. So essentially, there is no mandate for private insurance anymore. I believe it's still in the books, but the penalty is zero. So that is not a mandate for insurance. In the U.S., we have no price controls. We typically have monopolistic hospital markets. So we have private hospital markets, but typically these are dominated by monopolies. The hospitals have massive market shares in their areas. So this would not be like a free market competition situation. We have opaque pricing, meaning it's hard to know the price for things, or the price is not revealed at the time of service. We do have public insurance. So this is a bit of a misconception in the US that it has no public insurance. We actually have public insurance, and it's fairly large, for two key groups: the elderly, so this is Medicare for those over 65, and the poor. So we have Medicaid for low-income individuals. If your income is below a certain threshold, you qualify for Medicaid. So we actually do have a public insurance system for large swaths of our population. There's an emphasis, as almost kind of historically, the US has emphasized liberty. And this is really unique to the US. You had other countries that had something similar. They transitioned to a Bismarck system. Switzerland is the one I'm thinking of. Um, Also, it should be noted, we have this weird thing in the US where employers, uh, many people have their insurance via their employer. This was not designed, this was not intended. I don't think there's a good argument for why your employer should provide your health insurance. It's always, people are always going to mix up health insurance with healthcare. This is just a quirk of history. This is one of those things that just sort of happened by accident, and we are stuck with it because people got used to that's the way it was done. So where did this come from? World War II. So World War II, the government put price controls in on wages. The government was building lots of ships and tanks and stuff, kind of contracting these out. They wanted wages to be low. So they set a price ceiling on wages. Wages cannot go above a certain amount. If you're an employer, you're building ships, you're building tanks or whatever, you still need to attract workers though. You can't be competitive on wages though. You can't offer them higher wages. The government has said you can't put your wages above a certain amount. So what do? You have to find another way to entice workers to work for you. I mean, there's a labor shortage because, a lot of the population is off fighting the war. So how do you entice people to work for you when you can't offer them higher wages? You offer them other benefits. So they started offering health insurance and health care. Kaiser famously was a shipbuilding company. People got used to this. People were like, hey, this is great. I get this job and it comes with health insurance. This is fantastic. People got used to it. And it just became something that was expected of employers, although maybe that is changing a bit. But this is a quirk of history, and one of those things like the mortgage interest reduction where it was not intended, it was not designed, there's not really a good reason for it, but we are, unfortunately, for the most part, stuck with it. I mean, fortunately, I guess if you have good care, but even then, you essentially, if you have insurance for your employer, you're implicitly getting lower wages. I mean, they could have offered you higher wages, but that you cost $10,000, whatever it costs to insure you. So that's money that you could have got in wages instead of the employer paying for your health insurance. Okay, let's take a break there before we go into examining the relative performance of these different systems. Spoiler alert, here's a graph right here where you can take a look at it before I end this video, if you so wish.